Today we will see the topic of medicine, which is quite important in hematology, is CML, chronic myeloid leukemia. Chronic myeloid leukemia, we can see the risk factor by compare it acute myeloid leukemia. Chronic myeloid leukemia is most commonly seen in 51-year and 47-year female, while acute myeloid leukemia is 67 and 53. Acute myeloid leukemia more commonly seen in male than female. Chronic myeloid leukemia has same presentation, more seen in male. Risk factor of the AML is environmental risk factor, which are smoking, radiation, benzene, and drugs. While chronic myeloid leukemia, no risk factor, smoking has no risk, radiation is very long time radiation, benzene have no risk, one drug you should remember is etoposide, have significant risk for chronic myeloid leukemia. Some acquired hemolytic condition which is responsible or associated with CML is polycythemia rubra vera, primary fibrosis, or essential thrombocytosis. Now we see most important part of the CML is Philadelphia chromosome. Which is seen by examination of the cytogene examination, gene examination, we can see the Philadelphia chromosome. There are ABL gene which is situated on the chromosome 9 and BCR gene situated on chromosome 22. There is a reciprocal translocation. Due to reciprocal translocation, genetic rearrangement is there. Due to rearrangement, there is rearrange of chromosome 22, which is seen in 100% of the CML patient, but in 95% patient have shortening of long arm of chromosome 22. This shortening of short long arm of chromosome 22 is called as Philadelphia chromosome. Philadelphia chromosome seen in 95% of CML. Now we see the rearrangement of chromosome 22 lead to reactivation of BCR ABL tyrosine kinase. Due to BCR ABL tyrosine kinase reactivation, there is marrow proliferation marrow proliferation, hypercellular of the marrow. But in case of AML, there are non-differentiating, and in CML there are chronic stage. So maturation of the WBC occur at chronic stage. So all myeloid strain are there, and this mature WBC also release in the peripheral blood. So more than 2 lakh per WBC are there. There are RBC proliferation in initial stage, but after some time, due to excess WBC, RBC proliferation is held. So anemia occur. Anemia is 10 to 11 gram per deciliter Hb. Total platelet count also rise. More than 450 lakh platelet count are there. So thrombocytosis is occur. Now we can see the clinical feature of the CML. Mostly asymptomatic patient. Fatigue is there. Fatigue is due to anemia, massive spleen due to increased WBC, destruction at spleen. Massive spleen lead to left upper quadrant discomfort, abdominal distension, and massive spleen. WBC count is more than 2 lakh. So there is hyperviscosity and acne, urticaria, arthritis can also occur. There are some B symptoms are there. B symptoms are fever, weight loss, and night sweats. Now we can see the blood picture. Blood picture of the CML. We can see there is initial increased RBC count, but after RBC proliferation is in halt, so decreased RBC, and due to decreased RBC there is decreased hemoglobin. Anisopoikilocytosis is there. WBC are more than 2 lakh. WBC are segmented form, 35%. Segmented form are mostly neutrophil, and band form WBC are 15%. Eosinophilia, increase eosinophil count. Basophilia, LAP is low. Some other condition LAP is low is PNH, paroxysmal nocturnal hemoglobinuria. LAP stand for leukocyte alkaline phosphatase, increase T lymphocyte, natural killer cell are decreased, beta cell are normal. Now we can see the bone marrow picture. Bone marrow is hypercellular, decrease erythropoiesis, increase megakaryocyte, there is some characteristic cell are seen in bone marrow are C blue histiocyte. Bone marrow fibrosis is occur. It is occur in last stage. Molecular diagnosis is done by 95% have Philadelphia chromosome. DNA PCR can be done. FIS is also done. Chemical finding. Chemical finding, there is increase in LDH, increase in histamine, increase in uric acid, and angiogenic factor also increase. There are some types of the CML or some variety of the CML are the chronic neutrophilic leukemia, chronic neutrophilic leukemia is have BCR ABL absent, chronic eosinophilic leukemia, it have PDGFR alpha mutation. PDGFR alpha mutation, it is response to imitimab. There is juvenile myelomonocytic leukemia is also there. Juvenile myelomonocytic leukemia seen in child less than 4 years. It is presented with rash, anemia, pancytopenia, thrombocytopenia. Rash mostly defect in RAS pathway mutation. Now the stages of the CML. There are 3 stages. First is chronic phase. Chronic phase is good prognosis. It is followed by accelerated phase. An accelerated phase is followed by blast phase. Accelerated phase. Phase. Accelerated phase have main presentation is anemia. Anemia have less than 7 gram per deciliter Hb. Blood or bone marrow blast is 10 to 20 percentage. Platelet count is less than 1 lakh. There is formation of the new chromosomal abnormality. Bone marrow fibrosis. Blast. Blast crisis or blast phase. Blast phase is mostly resemble to AML, in which marrow or blood blast is more than 20%. LAP is increased. Marrow failure is there. We see the new chromosomal abnormality which occur in accelerated phase, which is P6INK 4A ARF. There is prognostic scale. Prognostic scale for CML is Sokal index, which compromised circulating blast, spleen size, platelet count, age, eosinophilia and basophilia. Now we can going to management phase. Management phase, there is must given treatment for tumor lysis syndrome. In tumor lysis syndrome, there is we give prevention of the tumor lysis syndrome. We can given allopurinol for excessive uric acid, given hydration, make a low LDH is at baseline, increase HDL cholesterol and minimal HDL cholesterol. Now we can going to pure treatment phase of the CML. CML have two type. 95% are Philadelphia positive, 5% are negative. In negative patient, only treatment is bone marrow transplant. 6 by 6 HLA matching is required for bone marrow transplant. And this 95% Philadelphia positive are given with imitimab, imitinib. Imitinib is BCR ABL tyrosine kinase inhibitor. There are many tyrosine kinase inhibitor are there. They are divided into three generations. First generation is imatinib. Second generation is nilotinib. Dasatinib. Third generation are bosutinib and ponatinib. There are some side effect of the imatinib is GI disturbance, edema. Edema is periorbital. Nilotinib have pleural PND and pancreatitis. Dasatinib side effects are pleural effusion, and pulmonary hypertension. And ponatinib is also useful in T13I mutation. When CML is occur with T135I mutation is only reply with ponatinib. Response to imitinib. Hematological response. Hematological response is occur in 2 weeks. In hematological response, there is WBCR decrease, platelet decrease, and not any single immature cell in the blood. Molecular response which are occur in the 3 months. In which BCR ABL mRNA level is going to undetectable by blood peripheral chain polymerase chain reaction by blood PCR. And cytological response is occur in 6 months. In cytological system, Philadelphia chromosome which are positive in bone marrow going to be negative in 6 month treatment of the imitinib. Lifelong treatment is required. And for response of the therapy is BCR ABL transcript which is measured by PCR. Rx of the accelerated and blast phase. In this allogenic stem cell transplant and last phase are treat like as AML plus imatinib. Last phase has very poor prognosis. So friends, this is my teaching about CML. Thanks for watching. Please share, subscribe my channel, like this video, share this video and subscribe my channel. Thank you for watch. See you in next video.